Ministry of National Security, Health, Education, Labour and Rural Development, Economic Growth and Job Creation, and the Ministry of Labour and Social Security. Yesterday, we were only able to get to the Ministry of National Security, so we have the remaining ministries that we hope to deal with this morning. So that makes for the agenda for this morning. Any apologies? Member Hamilton. Any other member? Okay. Well, I'm going to presume that all the rest will be coming, but late. New business, item 5. We'll go straight into the ministries. So could I ask that the Ministry of Health, along with the Ministry of Finance, of course, that will sit through all the deliberations. Oh, I indicated that you would be here. Welcome, PS, and your team, your CMO, other members of the Ministry of Health, Madam FS, and Ms. Jarrett from the Ministry of Finance. Sorry, yesterday we were not able to take your ministry, among others, because of how extended the previous part of the deliberations were yesterday, but happy to have you here this morning. We ourselves never planned on being here either as committee members, but circumstance caused us to reconvene today. PS, as you will appreciate, your ministry is one of the ministries that we chose to deliberate a bit more on. The supplementary budget is in most part a function of adjustments that have to be made in the budget that was tabled at the beginning of the financial year. So everybody knows we are in a health crisis or have health challenges, and you on the health side, of course, is at the forefront of it. And of course, we have other fallouts in the country on the economic side and the social side, education, etc., as a result of the pandemic and the adjustments that the country has to make to deal with the challenges. So, as usual, I'm going to ask you, PS, if you have any opening statement to make in respect to the reallocations, new allocations coming out of the supplementary budgets, changes in execution that warrants these new financing, etc., that the committee and indeed the country can have an appreciation of. So I'm going to ask you to lead.
So thank you very much, Chairman, and good morning to members of the committee. Chairman, I would prefer to go into the questions that may arise out of the submission by the Ministry of Finance and the Public Service relating to the supplementary estimates and the provisions for the Ministry of Health and Wellness.
Yes, as you will appreciate, the foremost subject for the Ministry of Health and the country is the treatment of COVID patients, and on the other hand, also the execution of the vaccination program island-wide. Those are perhaps the two foremost ones. And I probably want to start out by asking one, if you could provide to the committee a breakdown of the vaccination rates that across the country, parish by parish at this time, so that we know where you are, and also indirectly, why is it that the financial support is needed? So if you could provide that on the one hand, then some other questions will come from that. And the other one I want to posit from my side, and other members will have their own question, is the infrastructure, that is the hospitals, capacities. Each hospital across the country, I know a few hospitals have been retrofitted or reshaped to deal with COVID patients, etc., in addition to the field hospitals that would have been set up or being set up, and those to be set up to deal with the increased demand for patient care in the hospital. So to start, that's where we would want to get your feedback and then the questions. I have some further questions that will emanate from your responses.
So thank you very much, Chairman, and thank you for the questions. So with regards to your first question in relation to the vaccination program, so as at 8 a.m. this morning, the country has administered 802,017 doses of vaccine. Of that, 510,956 are for first dose, 260,040 are second dose, and 31,021 are the single dose Johnson & Johnson vaccine. Therefore, that represents a total of approximately 291,052 persons who have been fully vaccinated in the population, which is around or approximately 10.3% of the population that has been fully vaccinated. Another 9.4% of the population has been reached with at least one dose of vaccine. So the total reach of the vaccination program as at today's date, Chairman, is approximately 20.1% of the total population that has been reached with at least one dose of vaccine. The parish that has the largest coverage in terms of vaccination is Kingston and St. Andrew, with 72.5% of the population that have been reached with at least one dose of vaccine. The second parish is St. James with 76.7%, St. Elizabeth with 77.4%, and Trelawney with 79.3%. I will then state the other parishes in no sequential order. Hanover, 80.6%, Westmoreland, 83.2%, St. Anne, 80.7%, St. Mary, 83.1%, Portland, 87.1%, St. Thomas, 88.8%, St. Catherine, 85.6%, Clarendon, 85.7%, and Manchester, 81.3%, and Westmoreland, 83.2%. So that is the coverage of vaccination across the island at this time. In relation to
apologies, but these percentages represent?
I was coming up. What is it? Is it of the parish population?
Of the parish population.
So,
No.
if I'm trying to understand.
Sorry. So have not been reached.
Right.
Oh, I'm not been reached.
not been
Right,
reached.
Because those high percentage and the total.
It couldn't match. It didn't match to me, so I was.
Have
my
not been
apologies.
reached. So my apology. Have not been reached. So if you do the inverse, you will see the a percentage that have been reached.
Right.
All
Could
right.
you?
So no
Yes, thank
problem.
you.
So we can.
Oh, well, let me attempt to come to the defense of the PS. When he gives the higher number that is not, it tells you how severe the problem is.
Right. So I will have to now go through the process of doing the calculation. So for the purposes of the records, then I'll go through. So let me do the entire island, starting from St. Thomas.
PS, one of the difficulty, as you spoke, I was trying to catch them and I missed them. It would have been good if you had circulated that chart that we could follow it. I have captured some of that.
So we can circulate. We can provide the chart.
Okay.
It was provided, but we can provide it to the members.
Okay. Because this one is up to this morning, as you said.
Yes.
So this one stands above
Yes.
everything else. Okay.
Mm-hmm. So in terms of so I'll go through again slowly. So St. Thomas, of the total number of persons that have been reached by at least one dose of vaccine, that would be 22%. It's the reverse.
Sorry, I was just confused at the first about what they were curling, but now you know it's the not reached. You can use the same percentage; it doesn't matter.
All right, no problem. So in terms of the reach by age, so again, in terms of the persons not reached, 80 and above, 73% of the population have not been reached. For 70 to 79, 61% of the population has not been reached. 60 to 69, 63.9% of the population has not been reached. 60 to 69, it's 63.9% of the population that has not been reached. For 50 to 59, 69.5% of the population has not been reached. 40 to 49, 75% of the population has not been reached. 30 to 39, 80.6% of the population has not been reached. 20 to 29, 83% of the population has not been reached. And for 12 to 19, 81.6% of the population has not been reached. So the highest proportion of the population that has been reached by vaccination are the persons in the age group 70 to 79 years old. Where
Mr. Chairman, is it possible for the PS to perhaps just screenshot that image and airdrop it to the clerk and we can just share it? It might be a little bit easier.
Airdrop requires an iPhone.
All right. Is there another way?
I'll WhatsApp it, no problem. I'll send the entire presentation. If you could just...
that you have the numbers, it'll be more useful for the discussion.
Sure.
That's the point.
Yeah, no problem. I will. You can email it or... Your email. Give me your email.
For the benefit of time, we could continue. We will, well, I hope other members were able to catch the numbers. I get a sense of where the numbers are. I don't have to have the precise one for right now.
Quick question, PS. would we be able to separate, even by parish, have an appreciation of the rural areas versus the city areas, what the level of vaccination is, to see if there is a significant diversion? So like Kingston and St. Andrew, persons who are in New Kingston and in the environs, vis-a-vis places like West Rural and East Rural, and in other areas, I'm sure they would have the same issue. Is there a way to determine urban versus rural spaces, what the disparity in vaccination is compared to the total for the parish?
Yes, there is a way, and we are currently doing that exercise now. Unfortunately, we have not completed the geomaps. So what we are doing is that we are doing the spatial distribution based on the addresses in our database. And then we'll be able to show on a map, constituency by constituency or community by community, using this, the starting SDC communities to show where the majority of the population. And the good thing about it is that we can do it by ratios, in that we have the number of persons in terms of population in each community based on that. So we can do the ratios and we can come up with a map.
Yeah, but one of the pertinence of member Owens' question is to establish the extent to which, you see, if you go by center, as you just mentioned, people can be transported into those areas and to be captured there. What she wants to speak to, and all rural MPs would have an interest in that, like those deep rural communities, right? The extent to which they are not vaccinated, and you know, when you look at these numbers, for example, in the rural, just parishes overall, the numbers are very frightening that you don't reach yet. And it brings to another question, which we want to go, is what is the arrangement or arrangements being made to properly service these deep rural communities? Some mechanism, and this speaks to the heart of the vaccination program, how agile it is, how responsive the service is to the community needs that exist. Because when I look, for example, at Kingston, have a 72.5% that is not reached. That is 27.5 that is reached. And we'll say, okay, it's urbanized center, so the numbers are large. And that will go for the Kmart area of, well, when you include St. Catherine, Portmore, Spanish Town, to be large. But in Jamaica, everybody wants to be treated equally. So while you have a large number catching the urban area, the rural areas, people, they want to get vaccinated too, because they want to live. So how is it that is going to reach them? You know, so that's the gravamen of member Holness's question about that information. I can better inform where we are. But I want to come to that little later on in terms of the program itself, because quite frankly, PS, this is a national emergency, and as I said to the Planning Institute yesterday, everywhere else in the world I look at, while vaccination is a health exercise, a medical exercise, it is essentially a logistics operation. How to organize to get it in the areas that we need to get to. One, with the efficiency, with the alacrity that is needed, with the reliability that is needed, with the level of access by the persons in those communities to go there. All of those issues, which are not health issues, those are really logistical issues that we need to make sure it is being done. So in the Ministry of Health, the medical people, fine, doing what they are trained to do and can do. But, you know, and no one in the Ministry of Health have a feel anyway awkward. The country has never faced this before. This kind, we have vaccinated persons over the years, which is primarily children, but those are captive audience. They are in the schools. You can just go there and vaccinate them. This national vaccination program involves everybody wherever you are, not in a school or in a church. Anywhere you are, you in your rural farm, the what have you. It's very different. We have never been there before. But we have to use the sciences. We have to use sciences in terms of organizational science. We have to use the methodologies which have been proven across the world, other places. It's new to us, but it has been done. And we have to just adopt those things to let them work for us and to save our people. That is, come back to the question asked about the rural areas. That's where we are. And I submit to you, PS, we are hopefully behind. Hopefully behind. It's worrying. So.
Mr. Chairman, if I may.
Member Hannah.
And I strongly support the government's vaccination program. I believe in vaccines. I believe in the science behind vaccinations. And I believe in Jamaica's primary health care facilities and our system. And the research shows that back in the 80s, when we had the 4th polio outbreak, the country went into a national vaccination program. But it really took us 3 years to get to mandatory vaccines. This one is different, Mr. Chairman, because at that time, we really only had one radio station and one TV station. Now there is so much information coming to people and misinformation about vaccines. And so, as a part of the vaccination program, I would like to ask, because I remember when it started out, it was more on a blitz side. And I say to people all the time, measles, rubella, and polio are not running around halfway tree because of the systematic vaccination programs that we had put in place. We actually got rid of measles in Jamaica. How will the additional funds that you have here, apart from the compensation of employees, how can we better use them to get into people's spaces? There was a time when community health workers lived in the communities of rural areas. So if you had a question, you go down to the doctor, the midwife. That doesn't necessarily happen anymore. So I think we need more boots on the ground. So I'm asking, how will these additional funds help in getting more information on a one-on-one perspective to people so that they don't necessarily have to come to you? And what are some of the manual tasks? Because I know MPs have been having vaccination blitzes as well, but that's also mobilizing. But I think PS and CMO, we need to get to a one-on-one. I've had to spend copious amounts of time, sometimes 1 hour, 2 hours with just one person, trying to convince them about the fact that this is not some new technology that the world is throwing on you. The fact that this is not going to alter your DNA. The fact that this is not something to kill off black people. So I'm just saying, how can we use the funds a little bit better to get onto a one-on-one, face-to-face conversation?
Said Member Hannah, I could not agree with you more. It is part of my questions for MOH as well, because that is my experience coming from a rural constituency.
And that sentiment is widely shared here. And I think many outside of here too.
And that sentiment is also part of our concern as well. As a Ministry of Health and Wellness, we are very aware of our limitations. And we are very conscious of our capacities to implement programs, because as a Ministry of Health, we do not have the luxury of stopping other programs. Our maternal health program has to be ongoing. Our regular immunization programs have to be ongoing, because we understand the implications of those programs faltering as well. And so we are very conscious of the limitations in our capacities. And so we have encouraged the collaboration with as many stakeholders as possible. We encouraged the collaboration with the members of parliament and the councillors, and we provided resources. Over $200 million was provided to the Ministry of Local Government and Rural Development for the mobilization to be done with councillors and members of parliament. We have encouraged the collaboration with the private sector, and we provide in two different ways our support to the private sector. Through the private sector vaccination initiative, we provide all their vaccines and sundries, and they have been going out to different agencies and different firms to vaccinate. We have encouraged through the private sector as well our collaboration with private medical facilities. We have now established 11, soon to be 15, contracts with private providers to provide vaccination. We have collaborations with NGOs. We have collaboration with AFH, AIDS Health Foundation, and other NGOs, American Friends for Jamaica, all of those. So we have we have tried to facilitate a big tent approach to vaccination, because we recognize that this is not a Ministry of Health initiative alone. This is a national initiative. Yes, the Ministry of Health is the technical lead, but it's a national initiative. And we have utilized all our resources to ensure that every stakeholder has the capacity to mobilize. One of the examples that you will find is that most of the members of parliament that have sought to mobilize in their constituencies have come up on the real issues of hesitancy. And the fact that, yes, we have a target of 400 persons to come out per site. That's a target. But how many members of parliament have been able to mobilize 400 persons to a site? It's tremendously difficult. And some of these members of parliament and councillors are in the far reaches of their constituency in terms of their mobilization. And their efforts are tremendous. And most of the times when they put in all of this effort and spend all of these resources to find taxi man to move people from them home to the center, to do all of the things, the results of it in a lot of instances are not as significant as we would have wanted. The other aspect of our work is the private sector interventions that we have done. And the private sector vaccination initiative led by the Private Sector Organization of Jamaica had a lofty goal of 20,000 doses of vaccines per month. They are now, after about 4 months of operation, they are just getting to 20,000. And this is with the private sector going into the firms, into the business places, setting up the vaccination center in the hotels, in the BPOs, and saying to the employees, come. And not only the employees, saying to the families of employees, come. And they have not been able to mobilize as efficiently as they want. So there is a question around how do we begin to engage the entire society into this conversation. And I accept the fact, and it is a fact, that this is not a Ministry of Health initiative alone. It's a whole of government initiative. It's a whole of society initiative. And therefore, all of us have to move in terms of how do we achieve the target of 65% of the population vaccinated by March 2022.
PS. I, personally speaking, I very much appreciate what you have sought to convey in terms of this position. But a couple of things to be corrected in what you have said. Like all of us here as members are members of parliament. I've heard the announcement about support for MPs and the request for MPs to support and assist in the vaccination. At one point, I was told one day before that it's going to be in Portmore and for me to mobilize my constituency to be there. And one of the rationale is that all of us MPs have experience in mobilizing people for elections and so on. So there's some innate capacity for doing that. And there's some truth to that. But there's a period between nomination day and election day. I say that to say that there's a period you have to plan to organize the persons who's going to go out, identify the persons, and all of those things. It needs proper coordination for those things to happen. So while it's good to say, yes, these opportunities are there, if they are executed the way that I know firsthand how it is done when I am to participate as my MP, it must fail. Right? In the instant case, I have one, just to make the point. I'm having a blitz in my constituency on Friday. At least I was told from last week, Friday, I'll at least have 1 week, right, to mobilize. And I'm going to do what I can. No, I had to pressure for it. It was strong representation. But the point I'm making, I don't want to get lost. MPs I know, I think all of us MPs are vaccinated. I'm fully vaccinated. We believe in it, as Member Hannah has said. We want our people to get it, right? But we can't assist in the process unless there's proper coordination. Is it the Ministry of Health to do it? Is it the Ministry of Local Government or wherever else? But it's one government we see, right? And who need to talk to one another. And we are left out there without any leadership in execution of this thing.
Mr. Chairman, I've had the PS, I wanted him to go a little deeper in the one-on-one, face-to-face that I was asking. And the reason why I asked that is I'm a little torn between my philosophical dependency on what I know is a science and the fear of people, because fear is where I think we need to address. COVID on its own has stripped people of a number of things, in even their courage in their own belief system. And I saw what it did in the United States, in their political system. It became a political football, this vaccine. And now it's becoming almost another kind of football. And I won't say what that one is. But the reason why I asked you the question is that I find that there is a lot of fear among our population because there's so much information coming. And I am wondering if the politicians are really the right people to be the face of some of the arguments with it. And the reason why I say that, country people believe in a them doctor. When their doctor comes or their nurse comes, and I'm asking you, PS, how can we get, since you say that most of the programs, you still have to continue your maternal programs, the other immunization programs, how can we enlist more private doctors to go on the ground? How can we enlist more volunteers to go on the ground, to walk with us as politicians or with others, to just take the country by storm? Because when I was reading and when I spoke to people like Dr. Diana Ashley, for example, and when I listened to the CMO argue that the PAHO and WHO know we need to step in and get the international protocols fast-tracked, we all have an urgency here. And the fact of the matter is, we did it before in the 1980s. When the fourth polio outbreak came, we were able to give over 600,000 children their first dose of the polio drop. But that is because there was a real urgency of everybody coming together and understanding. So that's why I'm asking you, PS, how do you believe we can amass civil society to get the trust of our people to take this vaccine?
Chairman,
All three together.
Chair,
Member Enriquez.
can I just say one? Something that is that what I have observed is that one of the problems we're having is that when you go out there, you find that there's Pfizer, there's AstraZeneca, there's Johnson & Johnson. When the Pfizer section, because I had to divide them, the people flood it. When it's AstraZeneca, I have to beg people to come over to go take the AstraZeneca. And them say, if it's not Pfizer, I'm not take it. And there's these things that also are adding to, in addition to your point, that create problems for people to get it. And that's some of the things that I've observed.
So thank you very much for those questions, and the CMO will support in the response. So member, it is a fact that the trust deficit is an issue, and the fact also is that we do need to increase the presence of our public health and our medical officers in the communication, the hand-to-hand combat, as I would like to call it. And it is a fact that there needs to be an inclusion of more persons in the conversation. And it is a fact that we have accepted as the Ministry of Health and Wellness. We have then crafted a program, which we will be launching shortly, around utilizing the community health aides to get back into communities, into the health districts and the zones, to engage in that type of hand-to-hand combat. And they will be accompanied by the public health nurses and the medical officers of health. So there is a program that we will be moving to. This is part of our engagement here. And so we will be launching that initiative. As you are aware, member, we increased the number of community health aides by some 1,400 community health aides across the island. And so we are able, with this complement of staff, to more robustly go into the field. What we recognize, though, at the beginning of the exercise, the community health aides were heavily involved in the actual operation of the vaccination program at the sites. What we have done is that we have shifted that responsibility for the data entry and the data capture and the writing of the vaccination cards to other temporary staff that are non-clinical. But CMO, you want to add to that conversation?
Sure. Thank you, PS. Good morning, everyone. So certainly the utilization of our public health infrastructure to roll out the vaccine is very important. However, it has the rollout of the vaccine has transitioned over time because the initial impact was to get to as much people in one space. And so at that time, it was necessary to have large sites to be able to accommodate the numbers of people that would come out. Over time, though, the type of rollout has changed and continues to change because in our initial plan that we had put out, we had indicated that we would have started out with large sites and then moved to normalize the vaccination program within the communities in order to mop up the small amounts of people everywhere. And so now we've reached to a point where in all our health districts, so we have 63 health districts, and in all our health districts we have fixed sites. So regardless of whatever else is happening in terms of the private initiatives, in terms of the mobile initiatives, the other mobilizations on the ground, there are fixed sites that persons can reliably go they are open for persons to be vaccinated. And even if it is that you do a mobile outreach and it is that people are hesitant at that time, then the information should be passed to them to say that these sites are open. So, pass it on. At another time, you may change your mind and these sites are reliably open. In addition to the fixed sites, each parish does 2 to 3 mobilizations almost every week in terms of reaching to communities that they know are difficult and people will not come down to the centers. At this time, it is difficult to do the vaccination in every single type 1 and type 2 health center, because how those health centers are operated is that they're not open every day. They're open once every 2 weeks or once every couple of days, and some staff comes out at that time. Some of them are difficult to reach, so in terms of having any kind of emergency response, it is difficult to set up a vaccination site. So we've carefully selected those fixed sites within each district. With every mobilization that we have, we utilize our army of community health workers. So we have the cars that go out giving the messages. We have the community health aides on the ground. Now, certainly over the next couple of months, this part of where we are in the phase of immunization is what needs to be strengthened in terms of mopping up all of those small persons. In addition to that, we have now put on our website the ability for persons who have special circumstances and they cannot get to a vaccination site to register, so that we can know where they are, so that we can make arrangements to get to them. So, it is the rollout has changed over time, and it is the plan to get it to the point now of normalization within what it is that we know, because we've gotten rid of the volumes in terms of people wanting to come out, and we now need to improve access. So our plan over the next couple of months, couple of weeks, is really to increase access, and to really to get one-to-one with persons to get them to come out and vaccinate.
Go ahead. Member Holness.
Yes, I have several questions I would love to ask. I'm going to first start with our children. You indicated that in the age group 12 to 19, I wish you had given us 12 to 18, that 81% remains unvaccinated, which means that we have only been able to vaccinate 19% of our young people, and probably less than that. Again, I'm going to come to my concern yesterday. Since Pfizer is the only vaccine that WHO approved for children, why did we decide, when the government clearly indicated that children was our priority, to give the vaccine to adults? I thought that we were genuinely making a push to get children back into school with face-to-face. And so the focus would have been giving Pfizer to the children. That's my question one. I want to appreciate, I would have had my own vaccination blitz, so I spoke with you the evening after the vaccination blitz about the varied issues I found on my program on the day. I won't get into a lot of it. But I'm wondering if the Ministry of Education supported the decision to give Pfizer to adults. Would love for you to answer that, and not exclusively to children. I want to know where was the Ministry of Education on it. And did they, at any point in time, make any indication that we should make a decision to give Pfizer to adults from that end? I'm trying to also figure out a question I asked yesterday. Why did we give more vaccines than we knew we had second doses for? because we are not guaranteed the second dose of Pfizer. If we're getting it from the US, if we're getting it from elsewhere, we have observed that historically, these countries take care of their citizens first, and we have to wait until they decide that they are going to give us this particular vaccine. Why could you not at a lot of the sites? So we took our children to be vaccinated at JC, and I visited other sites. So once persons come to be vaccinated with their child, Pfizer would be at that center. So JC as a school, you come, Pfizer is there. So we'd vaccinate the child with Pfizer, and equally the parent would end up getting Pfizer because they're with their child. Many of the sites had Pfizer only, when we could have taken the approach to say Pfizer for the children at the same site and AstraZeneca or Johnson & Johnson for the adults. As a rural MP, my experience was, yes, you gave $200 million for mobilization to councillors, members of parliament. I've not yet received my allocation, but it is there, and I'm aware it is there. To organize a vaccination blitz for the first time, I had 2 days' notice. And then it got so deep that you had to provide all the transportation for persons to get there in a rural space. You had to provide your own tent if you didn't have adequate classroom in the space. Had to, for me, provide chairs under those tents for persons to sit down. Then you had to turn around and provide all the meals for the Ministry of Health officials and the persons doing the data entry. So I believe that is a discouragement to many members of parliament who do not have the personal resources or ability to raise funds outside to be able to host a lot of the vaccination blitz that they would want to host. I can tell you that when I was at Mavis Bank in particular, because the day didn't go as well as I wanted to, I wasn't able to talk to enough of my constituents. And I made a comment that I am an accountant, not a medical professional. So I don't think it is really appropriate for me to be the one to say to persons, I am encouraging you to take AstraZeneca. But in my constituency where persons said, look here, if the vaccine never come to Mavis Bank School, I wouldn't get it because I'm not going to town. And it was pervasive. Why we weren't taking a policy in those spaces to say, look here, we're encouraging you to take Johnson & Johnson because when we come, it's one shot, it's over, you don't have to come back. Your MP don't have to transport you back, put another blitz together, find food, find money for all of this. Why aren't we at that place yet? And I know that we have still also a lot of Johnson & Johnson that we're not pushing and a lot of Johnson & Johnson to come. So adding to Ms. Hannah, Member Hannah's statement, I am also concerned that my rural constituents do not pay any attention at all to PR statements encouraging them to take the vaccine. Very few of them do. If we have key influencers, JPs, teachers and principals, doctors, the clinic and the nurses, talking to them about the vaccine, it makes a difference. So I was able at the Blitz to encourage persons and say, look, we really are targeting children with Pfizer. I am encouraging you, allow our children to go back to school. And for the AstraZeneca, I said to them, it is what I took, it is what Prime Minister took. I am encouraging you, take the AstraZeneca. I didn't have Johnson & Johnson at the time at my own Blitz. And persons who I spoke to, I still encourage them, look, still consult the medical persons, but they made a change. So I was very shocked when I asked for the data for my constituency. Having moved so quickly through the day from Mavis Bank into Gordon Town into Bull Bay, and if you know the terrain, it was a lot to do in one day. And getting the statistics back, that 75% of my constituency got Pfizer. Those people have now started to say to me, Mrs. Holness, I'm hearing that this thing going to need booster and it going to need another shot. Otherwise, if I don't get the other shot and I don't get the booster, I'm not fully vaccinated. How am I going to come back out to go get another vaccination? And I think, particularly for rural areas, we have to give some special considerations, because those spaces will become harder and harder, and at the beginning got less and less of an attention in the dispensation of the vaccines. And once hesitancy starts setting in those rural spaces, it becomes so much more challenging for us to walk house to house to encourage persons of the need for us to be able to get back to business as a nation, that COVID is here for a long time, and that vaccination is the government's best option. I heard some persons complaining that I indicated the minister dispensed the vaccine. I didn't see the minister at Mavis Bank, Gordontown, or Bulby. I saw individuals from the Ministry of Health, not the CMO, not the permanent secretary, not the head of the ministry, but individuals now at the bottom of the rung, as nurses in particular, dispensing the vaccines, and in my observation, going far off from what was initially intended. I visited one site and the nurse lamented. She says, I don't want to be giving people Pfizer, but this is now my instruction and it does not make sense. So PS, lots of questions, and I'm happy to WhatsApp some to you.
Chairman? So I would just want to state categorically that there is a clear policy directive that we have received around the distribution of Pfizer. And that policy directive has come in the normal course of how policy directives are given to civil servants. And that policy directive was very direct in that the Pfizer vaccine was to be prioritized for children 12 to 18 years old. However, parents and guardians who accompany the children were also to be afforded the opportunity to be vaccinated with Pfizer. So I'm very clear in my mind around the policy direction that was provided to the Ministry of Health and Wellness. And so I understand the members' frustration. However, we are guided by policy.
On that note, you said the policy directives that came to the ministry. Mm-hmm. Correct?
Yes.
Okay, all right.
So, so in terms of that conversation, I think we need to be clear around what the policy instruction was. The policy instruction was clear around prioritization, but did not instruct exclusivity. And therefore, I am not sure how we arrived at exclusivity to the Pfizer vaccine. As a matter of fact, on the day that the Pfizer vaccines arrived in country, there were two press conferences. One press conference that was held at OPM, Office of the Prime Minister, where the Minister of Health and the Minister of Education articulated the same policy posture around prioritization. And then there was a second press briefing later in that day around the same issue.
How many children got Pfizer? How many children? How many children did we have to vaccinate to begin with? And if the policy directive is prioritize children, how many children, and I got a first dose, and how many children got to be able to get 2 doses?
Okay.
I won't even ask about the adults. And again, I'm saying it's unfortunate that we are gone all the way up to 19, but I don't think 19 should have been that material, I hope. The age group 12 to 19, if that's how the data was collected, or if we have 12 to 18, I don't know. How many were able to get the Pfizer vaccine.
But if I may, just to conjoin a question or clarification, I seek to Member Onus's question. If the policy directives is for priority on children, the addendum to include parents accompanying the children would now create an uncertain number, because the Pfizer is 2 doses. Remember, Onus have said that you know for the children you need to have 2 doses to have them properly or fully vaccinated. Unless you're guaranteed continuous supply to meet that need, there is limitation on how many children you can fully vaccinate if those are your priority.
All right. So,
Mr. Chairman, hold on.
So
a second,
before,
can I just
okay, sorry.
add
Go ahead.
to what Member Holness and the Chairman has said? On, I believe it was September 15, the Minister of Education came and she said out of the 211,000 plus children between the ages of 12 to 18, 73,870 had received a COVID vaccination. So if you could probably clarify that, because that came from the Ministry of Education.
Right.
And also, I'm aware that we were supposed to get 600,000 doses of Pfizer from the United States. We have gotten, I think, 202,000.
208,000.
Which came in the first shipment. When will the other shipment arrive, the other shipments arrive? So if you can just add those to the...
I'm sorry I asked about that question, because I would have loved to stick to school a little bit. I don't want to confuse PS. PS, add to that, we are prioritizing children. You're better equipped than I would be. What would have been the problem in us saying to children, come out to your various schools? We're going to take 1 week or 2 weeks, 7 days a week, and we're going to literally focus vaccinating children first to get them out to school. And then, if we have leftover Pfizer, to the adults. But before that, I would love to know, based on the dosage of Pfizer that we had and the number of children that we needed to get to, what was the correlation in being able to vaccinate our children?
So, I must step back, member. The priority of the vaccination program in its genesis, its entirety, is the vaccination of the vulnerable. And therefore, so the vulnerable population, who will be the worst impacted by a COVID-19 infection? That point has to be at the forefront of the mind of every policy deliberation that we have had. The reality is that the vulnerable population for COVID-19 are persons 60 years and above. Now we have a vaccine within country that is to be utilized to inoculate the population. We have this vaccine has been proven safe within children, and we have prioritized children for this vaccine. But it does not dispense, nor does it discredit the first function of a vaccination program, which is to protect the vulnerable. And therefore, our conversation cannot be and should never be around exclusivity of any vaccine. It has to be providing the vaccine to the population that is most vulnerable. Now, in the context of the conversation around whether or not we made the right decision to inoculate the safe vaccines for the second dose, there were two conversations at the table. And in a vaccination program, there's always this conversation in the space of scarcity. And there's a clear discussion paper provided by the WHO on this very matter. The conversation was, do we provide vaccines to 100,000 people and give them full protection? Or do we provide vaccination to 200,000 people and provide partial protection? In the context of us going through a surge in COVID-19 cases. Now, which of these present the best option, given the fact that it has been shown that the efficacy of the vaccine can last up to 12 weeks after being administered the first dose? So our position has to be one in which we weigh the cost benefit of the two options, of the two policy options. Now, we know that a lot of persons are anxious around the second dose, and we, in our deliberations, took the decision to continue the administration of doses with the assurances. Yes, hindsight is 2020. The assurances have not yet come to fruition. However, what we do know is that the protection that we have provided to these 200,000 persons have not yet been lost. And therefore, from a public health perspective, one can argue whether or not giving one dose is more efficacious than giving two doses. But from our position, we believe that having 200,000 persons receiving some protection is a better argument than to have 100,000 persons receiving full.
Yes.
From where I am seated.
Yes, we don't disagree with you in that regard. However, when we are at the place that we have significant volumes of AstraZeneca, significant volumes of J&J, I have not seen a push that says take those vaccines, so that in terms of the numbers that we are trying to get to, we are in a better place. If we create the perception that Pfizer is the Clarks of vaccination, and that's... no, I'm serious. If we create that perception, how then do we go back to pushing AstraZeneca and Johnson & Johnson, which we know? I listened to the information, I have read enough. I know the vaccine I got from you at the Ministry of Health was a good vaccine. AstraZeneca is going to be with me, producing antibodies and protecting me to a significant extent so that I do not end up terribly ill at hospital if I contract COVID. So I am still concerned. I agree that the most vulnerable is first and foremost. No problem or debate there. But the most vulnerable had available 55 doses of vaccines that we ended up having to throw away. The most vulnerable, if from the MOH point, and I hope you don't miss my point, I think I was less equipped to encourage my constituents to take AstraZeneca or Johnson & Johnson. I think the Ministry of Health is far more equipped than I am to get that message to individuals. If their doctors tell them, MOH tell them, you are coming from a medical perspective. When I tell them, the only medical perspective I could have come from is to say, look here, that is what I took. So I remain concerned that when we look at the broad picture of not just MOH, but what we want with education, what is happening in terms of getting... Yesterday we actually met with PIOJ and BOJ. And we were made very clear, which is why the discussion started, that if a substantial portion of our population is not vaccinated, we stand the risk of not being able to afford the $10 billion that we are adding to the Ministry of Health's budget. of not being able to afford the additional $5 billion that we are giving out in care programs. So when Jamaicans understand that COVID is not here with us for 6 months or possibly a year, it may be here with us for a long time, and that the vaccines we have for adults are AstraZeneca and Johnson & Johnson, and that's what we are going to provide. They will come along. That has been my experience. When we have rules and we say, look here, we want to give this to the children, leave it for the children. Yes, they may not be the most vulnerable. I agree, that message has been sent. But if we want them to go back to school, it allows also for parents to be able to focus on work because they don't have these children to take care of. They want to go back to work. They want to ensure that their children are educated. And if after over a year of most of our children being at home, and we're hearing that they're falling behind, I can't understand how we got to a point of throwing away vaccines when we could have given it to those vulnerable adults.
1 second. So member, chairman, I take your point. I take your point, and I see what you're saying. However, I am sure, member, you understand that the evidence by your experience shows that the preference for Pfizer is not a function of us in the Ministry of Health promoting that.
Yes, I don't agree with you. Even though that's the result, not one person, medical professional, at any of those blitz gave any indication from the Ministry of Health to say, look, we are reserving Pfizer for children. But we would like AstraZeneca, which we believe in, to be taken by the adults. If you did that exercise and then the statistics bore out to be my reality, I would have been fine. But there is no encouragement, in my estimation from my observation, to the individuals to justify that AstraZeneca and Johnson & Johnson was a good vaccine for us.
I don't necessarily agree, member. I understand that your experience is unique to you, but no, I don't agree. I don't agree that the Ministry of Health and Wellness did not say or did not promote the efficacy of all our vaccines. We have promoted the efficacy of all our vaccines. And as far as we are concerned, all the vaccines in our supply are good vaccines that we provide to the population. What we are not taking account of is the fact that the population receives information around vaccines from multiple sources. A lot of persons receive information about which vaccine that they should take from their relatives abroad.
But yes, you're missing the point. A lot of the vaccination sites had Pfizer only. Pfizer alone was offered at a lot of the vaccination sites. And therefore, I still go back to the question. No, not my constituency, no, many of the sites. I can tell you only Pfizer was available at some of our vaccination sites. Nothing else. Nothing else.
All right, member.
Could I, before the CMOs,
get no indication as to how many of our children we were able to reach with Pfizer. How many of the doses, literally in number format, how many doses of Pfizer did we have, and how much of it got to children?
Remember, 81,000 children between the ages of 12 to 18 received a dose of Pfizer vaccine.
Okay, Chairman, I'm sorry to just...
no.
Yes, that's both 1 dose and 2 doses.
1 dose and 2
members.
This is very important for children, you know. So 81,000 doses would mean some persons are counted twice in that 81,000 doses if they got 2 doses?
No.
81,000 children got at least one single dose.
One single dose.
And so if we looked at...
P.S. I think
Yeah.
perhaps the 211,000 that the Minister of Education spoke about is in between 12 to 18 or for the secondary school students. Are we looking at the... No, what I'm saying to you, though, is I don't think it was the entire child population between the ages of 12 to 18. What I got from the Ministry of Education was that the secondary school population who were the priority. So that is what I
So
gleaned.
12 to 18, where is the secondary school population? So and that's why it's because a lot of the sites that were there were in schools. And a lot of these sites required majority of the vaccines to be Pfizer because they were in schools. So I take the point, but I want to be clear in the communication around the policy directive that we were provided, because it's very troubling to us on this side in terms of the civil servants, that we in any way, form or fashion would want to seem that we were derelict in our duties in adhering to policy directives and policy instructions, because that's the core of the business of the civil service. And so when the point is made that we may not have done so, it's something that we have to clarify and be very clear about.
Fair and reasonable.
If you could clarify.
No, remember, no, one
If
second.
that
No,
could be
one second.
clarified in numbers.
Remember, one. 1 second. Let me just try and get some order. What 1 second, member, or less? Much to and froing. But there are other members too who... No, I'm coming back. I'm going to ask, in terms of reconciling the numbers, we want the PS to give the response to that, the question of the reconciliation of the numbers. And then secondly, I want to allow Member Clark, who has indicated he wants to make an intervention, and Member Enriquez. So, right? You're after Member Clark? Yeah.
So Chairman,
could you just could you just respond to the question, the reconciliation of the numbers?
Sure.
With the age cohort?
So the reach is 81,000 doses of vaccine administered to persons 0 to 18 years. Of that, some 25,000 have been fully vaccinated. 34,000, according to the data that I have here, have been fully vaccinated, meaning receiving 2 doses of the Pfizer vaccine.
Chairman, please be patient. The statistics coming from the Ministry of Health is sometimes a little confusing. I'll tell you why.
Right.
We speak in doses and individuals, and very often 81,000 doses could be that it has been administered to, say, 70,000 individual children, because some are getting 2 doses, and that's what I want to make sure I clearly understand. So don't tell it to me just in doses, PS. Tell me, of the total number of children in secondary school, 0 to 18, how many individual children
have been fully vaccinated?
No, even partially. Even if they only got 1 dose, how many children have been vaccinated?
So the reach of the program for the Pfizer is 81,000 doses administered. Of the 81,000 doses administered, 34,193 are fully vaccinated. So you multiply 34,193.
So 12,614 children have received a single dose, and 34,000 children approximately have received 2 doses.
2 doses, so you multiply that by 2.
No, man, I did. So that's why I know only 12,000 children with 1 dose. Now, that means 34,193. So PS, 64,000 doses went to the 34,193 children. So if we have fully vaccinated approximately 34,000 children, and we are at about 12,600 single dose for children, what is our coverage of the number of children in the secondary school from 12 to 18 that we have been able to cover? A small percentage when we are indicating, though not exclusively for children, the policy was a preference for children and being in a place where there were other vaccines for adults. And that was the crux of my concern, because we are making no strides in getting our children back to school.
But member, that's a very difficult argument to make, because hear me out, member. It's a very difficult argument to make because children under 12 cannot be vaccinated.
That's why I asked you, children from 12 to 18.
Right. So if we're talking about getting back to school, then children under 12 in primary school cannot be vaccinated.
No, but Pierce, with all due respect, I heard when you shift the definition from 12 to 18 to 0 to 18, right?
No. Sorry. No. My argument in terms of reporting,
yes,
it's always 12 to 18. So if I said 0 to 18, it's an error.
0 to 18.
It's an error.
But I construed it anyway to mean from the 12,
right,
since under 12 was not going to be vaccinated.
So my error, if that is what was said, that's my error.
Fair.
Yeah. So
but I think the point, though, just to conclude on the point, is not an argument to be made or not. I think the simple point is that you have 81,000 children. You only have done 64 altogether, 34,000 fully and 12,000 half. Well, the 34 fully dose would be twice that. That will be 68,000 plus the 12,000 would make you, roughly 80,000.
You see, I know that is how the World Health Organization and a lot of individuals report the numbers, so I understand the dosage. But I think instead of making things look glowingly like we have given 81,000 doses, when you really look at the reality and you have only vaccinated fully 34,000 children, it is a stark difference from 81,000 doses. When 12,600 children have only gotten one dose and only 34,000 children are fully vaccinated, is a stark difference from hearing a big number like 81,000 doses. And so that's why I was asking, because I really wondered. I'm not a part of cabinet. I speak for my constituents. So I have to go back and explain to them, if the Ministry of Education had an issue with the vaccines designated for X percentage of children to be able to set them back on the path of face-to-face, if they were in agreement to say, okay, just give it to the adults. And so that's why I asked some questions like, why couldn't the ministry have said Pfizer at the school plus AstraZeneca or plus Johnson & Johnson, so that the option was still there for parents to take AstraZeneca or Johnson & Johnson. And I know that you still have not gotten to a place of answering me in respect of my own concern. That person's now asking us, so why did we throw away 55,000 doses? When we were in a place that we actually needed those vaccines to be able to reach another segment of the population.
Okay, I think that is clear. Is that an argument to be made?
I will ask my last question and leave PS. The other concern I had was private sector. I noticed for persons I tried to get from the private sector to organize Blitz, and you said it, that private sector was on board. They were being charged an amount, I think, of approximately 472,000, something about 3,105 US dollars for them to organize the Blitz. So, Minister, when we have this massive when we have this massive budget for the Ministry of Health, how can we want to encourage private sector, encourage MPs to be a part and councillors to be a part of this facilitation. And then we are saying to private sector, you have to contribute when they are getting the vaccines free. They are the ones putting up their own tent. They're the ones putting in their chairs. They're the ones feeding the individuals. Yes, there was something called US $31,005 or something. The equivalent was $472,000 that they were required to contribute under the private sector vaccination initiative. So for me, if we want to get this thing out, anybody in private sector that is willing to host a blitz, I couldn't see myself charging them anything. I would say I welcome you hosting the blitz. You will probably have to hold on until we have adequate manpower, because we know we have a challenge in terms of the volume of doctors and nurses, but I couldn't see us charging them. And in terms of the depth of distribution, I heard CMO say we are like at 11, I think, private doctors or nursing facilities. Why aren't we much further along? And are we going to push getting there faster? East Rural St. Andrew is far from Papine for the most part. Mavis Bank is close to St. Thomas. We do not have, though we have 3 clinics across the constituency, 1 permanent vaccination site that we could utilize to have our rural citizens going to get vaccinated, though many are willing.
Yeah, let me take Mr. Clark's question 2, and you can answer them together. And members, we are now 11:45 to go, so we want to be mindful of that. But you can appreciate, PS and Ministry of Health, that this is the overbearing issue for all MPs. So let me go to Member Clark, and then Member Hannah, and Member Enriquez. And I have a couple of my own too.
Thank you very much, Mr. Chairman. Obviously, the long wait on Madam Holness she would have asked one of the questions that I wanted. The one about private sector was burning on my mind to ask, but I'll go to my next question, or concern as it is. Why is it that we find ourselves more reactive than proactive in the fight against COVID? I say this. I realize that we are responding quite often to what we see on social media and sometimes in our mainstream medias. And I think that we are on the defense rather than on the offense. I remember days back then, GIS would be used to go from, especially the rural communities, Madam Holness, they would go into these communities and they will set up them slides or whatever, and they would give members of those communities a first-hand information on what to expect or what is happening. I don't see that anymore. I wish to say to you, PS, that part of your advertising program would be to engage GIS, to go back into the communities and to start that advertising program, because even though we have persons who are willing, by virtue of me telling Tamika telling her mother, that kind of advertisement. Apart from that, we find ourselves, a lot of persons, Mrs. Holness spoke about it, and I'm saying to you that I had the same situation where on the day of my blitz, I had to drive to people whom to say, you need to come out and go take the vaccine because this is what. And it gets tedious because how many homes can you drive to? How many persons can you speak to for the day? What we're asking is for you to look at the GIS agent, the agency, to have them going out there long before and to get people up to speed as to what is AstraZeneca, what is Pfizer, what is Johnson & Johnson. Are they on the same level? If so, what you understand where the picture is being painted? Because if we don't do that, the anti-vaxxers are going to kill us. They don't have to do nothing, All they have to do is say to a man in the bar, if you take one of the vaccine, you can't have no more picnic. Those are simple arguments that they're sending out there. They are saying to you that 2 years' time, look how long 2 years from now, you won't see anything happening to you until 2 years' time down the road. Now, me as a man from Sheffield, Westmoreland, I drop out of school from Wapikil Philip. Me not on time for think through that. Me know say 2 years' time is supposed to be 51. And me not able to get no more kids or something drastic is going to happen to me. Me not take it. Me they wait for 2 years' time. Now the anti-vaxxers would have won long ago. So we're fighting a battle that we are unable to find the answer to if we don't step up and say, okay, we are going to go ahead. And we have to go ahead.
I want to move the conversation a little bit forward because internationally now, I know there is some urgency in terms of developed countries using vaccine diplomacy to hold developing countries like ours at ransom. I know the CMO in her most recent international conference has been lobbying the WHO and other international fora, as well as the Minister of Health and the Minister of Foreign Affairs, in terms of making sure that our vaccine numbers go up. Because recently, when the UK announced on October 4 that they just have they just have the red list, they no longer have amber. And so persons coming from Jamaica are actually not on the green list. And in November, the United States perhaps is going to go to a similar foray. When I look at my vaccination card, I'm going to hold up my yellow fever vaccine passport, and I walk with these every day, habitually. My vaccination passport for yellow fever has a WHO certification on it. My COVID vaccine has a Ministry of Health and Wellness. I know the minister has said that we are working on digitizing, especially the COVID one, because of how important it is. My question, therefore, is, can there be, in the meantime, for those of us who have been fully vaccinated, a certification stamp in our passport or a seal from the Ministry of Health with a WHO certification for the vaccine? And that's the first question. And CMO, how far along are we? Because I don't share the sentiments by some in the committee that the ministry has been pushing one type of vaccine. I'm aware that because one of the vaccines was not FDA approved, that many Jamaicans felt that it was not a good vaccine. So I'm asking as well, where are we with the certification for our vaccine, AstraZeneca, for example, going into the United States? And those are my two questions. When I say going into the United States, I know AstraZeneca has applied, but for those of us who have the AstraZeneca, what are we supposed to do in terms of those of us who have been fully vaccinated with AstraZeneca? Since the UK has one set of vaccines approved, which is AstraZeneca, Moderna, etc., and the United States has one set of vaccines, which is Pfizer approved. And I think some of that, too, PS, is where the Jamaican population is getting mixed up. So I'm asking, tell me about my cards.
So I will ask the CMO and the clinical team to respond to that question.
Right. So we would have to wait on the WHO to give that international certification, which is what the yellow card vaccination is about. The yellow card vaccination is an international certification. And so we would have to wait on that process. We can't just put the WHO stamp on the card. I can't say. I think in terms of the acceptance of the AstraZeneca, I'm not in the US. I have not seen anything in terms of the US not accepting as yet. I imagine that when their protocols are clear, then we would be informed. But it would be probably other entities that would need to have that conversation in terms of the acceptance by the US. I just want to say, to make two comments that I had wanted to make before, Chair, if that's okay. Certainly, the pushing of the AstraZeneca and the Johnson & Johnson vaccine is really something that we are doing. Member Holness, it is always difficult to get medical officers, experienced persons, advocates on the field for every immunization site. We do depend on our health education officers, and maybe we can work with them a bit more in giving information about all the vaccines. So that is something that we can do, just to emphasize. But I know that certainly at sites that I've been to, we've addressed the matters, and I think that when there are people there that are with more experience, then it makes a lot of difference. But especially as we open up more access points, it gets more and more difficult. But it is something that we can do to see how we can reinforce that message. And just to say, for all the persons that are listening, the AstraZeneca vaccine still is the vaccine that has been reported to have the least side effects, very good side effect profile. And as a matter of fact, right now, even though Pfizer has gotten their approval by the FDA for a booster, a third dose, and Johnson & Johnson has done the application, the manufacturers of AstraZeneca are still saying that there is no evidence to say that we need to have a booster as yet, because the vaccine is still holding up, showing good antibody levels, even at this time, 6 months and more after the second dose. So, the AstraZeneca is a good vaccine, and we have a lot of it. Right now, we have over 300,000 AstraZeneca vaccines. We have a lot of persons that are due their second dose, quite a bit that have missed their due date, that they need to come in to get their second doses, and for those that are due their second dose in October, to ensure that they come out. It is a very good vaccine. Like yourself, I myself have gotten it, and all the members of my own family. I wanted to comment on your advocacy for the children getting the vaccine, and I understand and appreciate it. However, I really just want to caution us that, again, a reminder as to who our vulnerable population is, and getting the children back to school is more, or should be more, hinged on getting that percentage vaccinated among the elderly up. Because the majority of persons that are affected are actually in the 20s and in the 30s. It's not below 18. And so the vulnerable persons are going to be more likely infected by the 20-year-olds and the 30-year-olds. That is what the evidence has shown so far. It may change when the kids go back out to school, because we may see their numbers going up, but certainly the evidence so far is saying that it's the 20s and the 30s age group where the majority of cases are, and therefore the vulnerable persons are more likely going to be affected by them. If it is that we had a 60% vaccination rate among our elderly persons, then we could be more confident in sending the kids back to school, because we know that the hospitalizations and the deaths would not be up there. So yes, I understand the advocacy for the children, and I share that advocacy because certainly people use it as a measure to say we're ready to get them back to school. But don't forget that where we want the protection to be among the vulnerable population.
Dr. Mackenzie, since you're on the question of the inventory, you said 300,000 plus of AstraZeneca. What is the complete inventory of what we have? And while you're getting that information, I just want to.
Chairman, add to that question. Could we get a separation in terms of whether or not any of that is close dated, so that we start pushing from now?
Post-dated?
Close dated. What I find is very often when we indicate that we have X number of doses that will expire Y time, it is just too short sometimes a notice to get a push. I don't know what it is about Jamaicans, but when they hear that the vaccine expiring, far more people seem to come out to get it, so that they can make it before the expiration date.
Well, there's another side to that too.
So how much do we have that is possibly expiring in October, so we know that we're okay, or in November, so we know that we are okay in terms of the lead time that we have to be able to dispense the vaccines?
Okay, so provide that information. The other one question I want to have answered, and the CMO is probably the more pertinent person. You mentioned that there are some persons who require a second dose and their appointment dates have passed and they need to come in. Those that require a second dose, whether it is Pfizer or AstraZeneca, how soon before or close to the appointed date can those second dose be given?
Yeah.
Chair and member, let me start by giving you the numbers of the doses that we have at this time. So we have, as at this morning, 268,280 doses of the AstraZeneca vaccine. That will expire on the 31st of October, 2021. And that is what we have at central stores. In addition to that, we have another 100,800 doses of AstraZeneca that will expire on the 30th of November, 2021. So in all, at central stores, we have 369,080 doses of AstraZeneca vaccine.
Yes, that sounds large. Over 200,000 doses will expire in less than 4 weeks, just to make sure we're absolutely clear, because it means that we have 200,000 doses of AstraZeneca that we have to push to get out to the public. In less than 4 weeks. It's the 6th, and you said they expire by the 30th?
The
non-vaccine, okay. All right. Doctor, you were not finished. You started.
Just one observation, Mr. Chair, in relation to what Doctor just mentioned. For persons who have appointment for the first week of November, could you forward those appointments for them to come in at the end of October? Can that be done? Because I know of many persons who have an appointment for November 1, 2, 3, 4. So could we forward them and get them into the batch?
Chair.
By the 31st of October. Just before, could you just state your name for the answered writers?
My name is Melody Ennis.
Dr. Melody Ennis. Go ahead.
Chair, in terms of I'm glad you asked that question, so we have an opportunity to clarify where this is concerned, because so much has been said about this about getting vaccines early. Now, for the AstraZeneca, the recommended second dose is 8 to 12 weeks, okay? The studies certainly have shown that the vaccine has a better efficacy the longer the time between the doses. So when we started out giving AstraZeneca, we were given 10 to 12 weeks. Because we wanted to use up doses, we had come down to 8 weeks. Understanding that we needed to get the doses out because at that time we had doses that were going to expire and we needed to use them up. However, we have to appreciate that the longer the time, the better the efficacy. Now, persons have been asking about if I come 24 hours before, if I come 48 hours before. Now, the time period that is given is 8 to 12 weeks. So I would advise persons to keep their appointment dates. We don't have a situation, and the ministry has really gone out of its way to make sure that we have vaccines that expired at the end of September, we have vaccines that expire at the end of October, we have vaccines that are expiring in November, we have vaccines that are coming that are expiring in December, we have vaccines that are coming that are expiring in January, in an effort to ensure that persons who would have gotten a first dose would have a adequate time that they are able to get their second dose. So we don't have a situation where we have to tell persons to take the vaccine earlier. We don't have that situation for AstraZeneca, not presently. Now, it may be that in the future we may have a situation that we have to vary from what is norm, but at this time we do not have that situation. And so, in terms of giving persons appointments to come in, it is in an effort to create an order. If everybody thinks that I can come in 24 hours before and I can come in 48 hours before, why not a day before that? So why not 72 hours? Why not 96 hours? If we have that kind of situation, then we're going to create chaos on the ground. The fact is, just as Member Holness wants to have somebody experienced on the ground to be able to talk about the vaccines, we have to recognize that we have a variety of workers that are given the vaccines. And for them to be able to exercise that judgment every time, 24 hours, 72 hours, it is difficult. And so, therefore, we try to stick within the time. Our instruction to the field has been to exercise flexibility. And in a lot of instances, when this has happened, I have spoken to each medical officer individually to say, have you been exercising flexibility? And yes, they have been. They have weighed the cases, and some persons they have chosen to give. Some persons they have chosen not to, because your due date is a week's time. I understand that if somebody comes today, you want to give it to them today because you don't want to risk them not coming back tomorrow. I do understand that. But the message that we give to the public must be that keep your appointment date. Flexibility, I agree, must be exercised, but it is exercised on the ground. I cannot afford for the public to exercise that flexibility because that will create chaos at our vaccine centers.
There's a follow-up, Mr. Chair. There's a follow-up. Because I raised the question.
Yes.
And the reason why I raised the question, I'm not sure how you do your appointments, but if somebody came in today for vaccination and you give that person an appointment to come back 8 weeks' time, isn't there any case where you would have given appointment for 8 weeks, 9 weeks, 10 weeks, 11 weeks, 12 weeks? That's the point I'm making. So if those persons who would have gotten a 9-week appointment, given that you have 4 weeks, 8 to 12, you could ask them to come within 8 weeks instead of 9. That's the perspective from which I was looking.
But And again, as I say, flexibility has to be exercised on the ground. But we use those appointments to gauge our availability of vaccines. So, for example, of these 200,000 doses of AstraZeneca that we have 170,000 persons that are due second doses. So, some of them could have been given 10 weeks appointments. Some of them could have been given 12 weeks, but we have to gauge the availability of the second doses on the appointments that we give.
But that you have the numbers, how many vaccines you have. So I was thinking that you could do some recalibration in terms of, making that adjustment in relation to the 8, 9, 10, 11, or 12 weeks appointment that you would have given to those persons.
Right now, the persons that have appointments are 8-week appointments. Initially, when we started out, we were given 10 to 12 weeks, but right now it's 8 weeks.
Mackenzie, your response regarding the scheduling and the second dose. I witnessed a situation about a week and a half ago. Prior to then, the ministry was accepting persons within 2 to 3 days getting the second dose before the scheduled dates. As a matter that I've raised with the PS, no public announcement was made in regards to adhering to the strict scheduled appointed dates. I have seen where persons have gone for the second dose within 2 days, 1 day, 2 days of the appointed date, and they were turned away by the center 2 days before. But it is a fact, and I have documentation to support it, where persons were being given the second dose within 2 days before the appointed days. At one of those sites, scores of persons within a day and 2 days of the appointed dates, some very elderly persons, right, were being turned away because you have 1 day more to go and 2 days. And 1 week later, there's an announcement, someone on one of the radio stations encouraging persons to come within a day or two. And when you juxtapose that with 50,000 doses being dumped because the dates have expired, I have a difficulty reconciling both. Because the persons that need the second dose, they are there. You have doses are expiring and they are turned away. And sadly, there are some very aged persons who are in that grouping. So when I heard you make mention, Dr. Mackenzie, about discretion, I wonder how that discretion, getting instruction from the center, and in fact, when I alluded to the fact that there was no announcement from the ministry in respect of those close dates, I was told they don't know what the ministry, they do what they do over there. The PS is aware of the case because I raised it with him. And I won't say publicly what was said, why the doses were not being given that day. Just for my own responsibility. I won't say, but I've said it to the PS. But many persons at that physical location, because I stood there and listened to what was being said. It wasn't said to me exclusively. It was being announced to everybody there. And my concern is that message that was disseminated by medical personnel to all who were there, the extent to which it can serve to compromise this national initiative. I feel very strongly about it because of the impact it will have on a program, this national program that affects so many persons. As somebody said, a dose that is dumped is like dumping a life jacket when the ship is sinking. That is the extent of it. And I'm very saddened, Dr. Mackenzie, that having raised it at the level that I have raised it, and the impact it will have for persons who heard, who was there, persons who were there. I've not heard anything said to alleviate those legitimate concerns, because persons who were in that situation voiced their very concerns to me. And it is in multiples. How many of them go back and say what they heard said? So I listen to you carefully. You talk about this discretion. I'm not speaking from hearsay today. I'm speaking from what I witnessed. And we can't be quiet on those things.
Not just discretion with the messaging. I remember indicating earlier that it would have been good to have persons of a particular caliber in terms of health officials at some of these blitz giving instructions and discussions. I would recommend if the Ministry of Health, even if you have new updates, could literally videotape the message that you would like to give out to persons coming to be vaccinated, and even persons on the vaccine, even persons who are not yet at the sites, so that we can disseminate those videos. And so when they get there, they're not totally dependent on the individual, because sometimes the deviation is because of the person at a physical location. However, if your message is coordinated in a way that that is the message that we play at every site when people come at 6 o'clock and the vaccines don't reach until 10, for 4 hours, they could have been sitting there and just continuously getting the information on Johnson & Johnson and AstraZeneca and the works. And they would get the information directly from the competent individuals who you trust to disseminate the same information right across, because we could help with that. We would be able to put up projectors if needed, just play it, transfer it via WhatsApp, so that you get your message across the board.
Member Enriquez. Okay. Member Anna? You had a non-vaccine
I have a non-vaccine question. I think may I ask a non-vaccine question, Mr. Chairman? Chairman? Can I ask a non-vaccine question? Have we closed it?
No.
We've closed the vaccine conversation?
No. That's why I said, I knew you said you had a non-vaccine question.
P.S. The support to the national HIV AIDS response in Jamaica. Can I have a 1-minute synopsis on where we are with the status of HIV in this country? I see where you have 254 million allocated to support the program, and I know civil society groups have been doing the program. So what is this money actually for?
So thanks for the question. I will have to give you the update on HIV AIDS program, the HIV AIDS program, in a subsequent submission. I do not have that data in terms of where we are with the program at this point in time, but I will provide that information to you. These resources are specifically because of what we are doing in terms of the reform of the program.
Right. Tell me about that.
These resources are specifically geared towards the integration of the program into the national systems. So because 70% of the HIV program at this point in time is funded by donors. And the strategic plan for the next 5 years is to ensure that we build capacity internally within the government system to absorb the activities that were usually performed by donor agencies. Part of this is the payment of staff that were usually paid by Global Fund or USAID or CDC. And so these resources that we have identified here in this supplementary is for that absorption of staff that are in the field and at head office that are usually working within and are usually supported, by Global Fund and other agencies. And to regularize.
The 63 million is for the purchase of medication, or I see where you have compensation at 121 million. What is will any medication
So that's one component. So the other component is the purchase of ARVs, which is also supported by the donor agencies. But now that we have nationalized the program, we have these resources now that we need to support the continuation of the clinical management.
Are you able to tell me what is the percentage of those infected with HIV in Jamaica currently, and has there been any movement along the line, or is it holding stable?
I don't have that data before me now, member, and I would really want to give you the correct information. Yes, I will definitely pass that to you. In regards to the question on the need, the private sector being charged to host events. So the private sector vaccination initiative that is operated by the Private Sector Organization of Jamaica have a model that they have worked through with the partners, with their members. And part of that model requires that their members cover the operational costs for the vaccination program once the vaccination PSVI initiative arrives on site. And they have worked out what that cost is. I'm not sure. Right. So that is separate from what government, so that's not a government initiative at all. So we do not involve ourselves in that transaction. That transaction is strictly between the private sector vaccination initiative and the private sector organization and the individual firm that they would then turn up in. So that's not necessarily part of what we do provide for that initiative is the actual vaccine, and the assurance of the MOU is that there's no profit motive in the transaction that is done. What the cost is to cover is to cover the staffing, it's to cover whatever other operational costs associated with the intervention. Sorry, at that particular site.
Yes, I think we should look at it though from the government's perspective, just to make sure that we can encourage more private sector individuals to take on the initiative, because if an organization is covering all costs themselves, they are doing the announcements, they're providing the space, the chairs, the tent, the food for everybody, so they're literally covering all the costs, but yet still are required to make this donation or whatever to the initiative, then many of them will be discouraged, I would think, or may not be able to afford it.
So remember, part of our collaboration with the private sector is that we do engage private sector organizations that outside of what the PSVI does. Caribbean Boilers, was it? It was Caribbean Boilers.
I know one particular company that was initially asked. Well, they started with the private sector group, but for some reason we needed to also do a vaccination blitz at the same location. And finally, we relented and said, "Okay, come under the government system.
Exactly.
You don't need to pay."
Right.
So I know that happened for
what
one.
we insist
I
on
would want us
when
to
we
encourage more
so
of
when
that.
we partner with private sector firms, what we insist on is that the initiative or the activation is not only for staff and it is for the community. So they involve the community, and we provide ours, and then we enter that conversation in that scenario. And we have done that in many a scenario in different private sector organizations across the country. So that's the response, member, to that question.
Thank you, Pierce. Well, my comment say more regarding the second dose issue. All right? As I said, I have a concern, but quite frankly, I don't necessarily want that answer here. The other concern I have, which I've raised with the PS, in terms of the pronouncements which were made about why the second dose was not being given.
So Chairman, I take your concern, and we will seek to review our current processes, and we will seek to.
I hate that I repeat what I saw take place again.
We understand, and and I must make the statement that we understand that the process isn't perfect, and we understand that there is a learning curve that we're moving through. The process has three components, Chairman. The process has a supply side component, it has a delivery component, and then it has the demand component. Now for the first phase of this, first stages of this intervention with vaccination, we were bedeviled by the supply side. And we have recently, in August, come to some resolution on our supply side. We still have some issues on supply side, as you have noted with the Pfizer vaccines. And so we do have issues around how supply affects the actual program and its implementation. Through the work of the committee that was announced by the Prime Minister, I'm sure they will come with some innovations for the improvement of the delivery model that we have. But to me, Chairman, I believe the mass of our problem is around demand and demand generation. How do we get persons to take the vaccine? And we have to, and I know that some of the problems that we have with demand generation is around the delivery model, because people are frustrated with the long lines and the amount of time. But it is the core of our problem now of how do we generate demand for the supply that we have based on the different access points that we have established across the island. Yesterday, we did 4,000 doses of vaccines across the island. 4,000. In order to meet our target, we have to do at least 15,000 doses of vaccines across the island. The argument around demand, therefore, has to be a whole of government, whole of society approach. I come back to that argument. I come back to that position, that a whole of government, whole of society approach to changing the dynamics around vaccination, building out the infrastructure, and getting people to getting people's behavior to move towards one of acceptance and mobilize it to get the vaccine.
Okay.
Yes.
Sorry, you finished? Mm-hmm. No, sorry. All right. I think there's a lot more, but time will not permit us to go any further. Just one last question. Is there any Pfizer vaccine at all remaining now? Or being given now?
So we do have a few hundred doses of vaccines that are in the parishes. Pfizer vaccines, a few hundred doses of vaccines that are left to the discretion of the regional health authority in terms of the administration of them. Because we recognize that we no longer have the capacity to meet everybody's need. And therefore, a case-by-case position is made on the ground, and the determination is made by the different parishes of how to dispense with the remaining balances of vaccines.
Just over a couple of hundreds, is there a couple?
A couple hundred, I think it's about 890 doses thereabout.
Okay, all right. I think we will close with the Ministry of Health, and quite frankly, from where I am, it's not that it's complete because we didn't touch, for example, on the build out for the what do you call the hospitals?
Cornwall Regional
Hospital and the field hospitals.
Yeah.
to deal with the treatment of cases. As a committee, we have to look at that otherwise. But for this morning's meeting, I don't believe we can go any further with the Ministry of Health. Thanks for coming. I'm quite mindful of the challenges that you face. You are at the forefront of this health challenge that we face as a country, and it comes with some bruises in the process. But you know, I know, for example, the medical doctors in their training, they would have been trained also to deal with warlike situations, and that is not the comfort of the hospitals or the surgery that you have to dispense services. So I know that you have that within you to respond to kind of like the social warfare that we might have in dealing with the pandemic. But I hope you can appreciate that many people are very, very concerned. And this is a question of life and death for individuals themselves, their families, and their loved ones. And so they become very sensitive. I want to thank you all for the services that you are providing. The country appreciates it, even though we have our complaints to make from time to time. The other element we also want to deal with, and the committee have to consider it, is the whole issue of compensation. We heard about the special payments. I saw the thing in it. We have not been able to go over those, but those are very pertinent issues. And why it is pertinent is because those issues impact on your capacity to provide the service that you have to provide. So those are other things. We never raised them this morning, but they are very pertinent to the supplementary budget and the health administration program that you are leading on. So we have quite a bit of incomplete issues to ventilate on and to hopefully give some resolution. And lastly to say, I've said it to you, PS, and I think I've said it to the CMO. When you come to these committee meetings, it is not for us to hammer you, but for us to strengthen you too in what you have to do, so that when we deal with the minister and the central administration for the support that is needed. For example, you mentioned about the limitations that you face, PS, in carrying out this task that goes beyond your ministry to achieve. This whole government approach you spoke about is not something that can be realized within your ministry. Our committee is here to do that. So when the report goes back to the House, we will be your advocates. We will be your lobbyists, knowing firsthand what you face and what we experience as committee members from constituencies across the country. So I want you to see these interactions in that context. Thank you.
Thank you very much, Chairman.
If NWA is hearing us from where they are, we want to have you in the chamber now. We have decided to take NWA, which is from Ministry of Economic Growth and Job Creation, that NWA falls in. NWA is going to be relatively short for the number of issues to raise. But while we are waiting on the NWA to join us, before we go on, FS, there's a question I had yesterday to ask of you, but the time did not permit. In the in the debt financing allocation, I wanted to specifically ask FS if the airports, I gather the Airports Authority was supposed to provide $5 billion to help in the refinancing of the budget. Is that $5 billion requirement still on?
Yes, sir.
Any timeline for it?
Okay, so we have received 2.5, I believe, this month.
Sorry, you have received?
2.5 billion already.
2.5 billion?
Yeah, the rest is due in the last quarter.
And the other 2.5 is due by when?
Yeah. Yes. Yes. Yes.
No, it's due by when?
March.
March next year?
Yes.
Okay. Mrs. Swell, welcome. Good to have you, and good to have also Mr. Hunter with you. And he's always delighted to be with you too. I think because he can see how much more money he can get from you. For your ministry, Mrs. Swell, it is essentially the NWA. And I could be a bit specific in one of the questions I have. But first of all, I'm going to give you the chance to make any umbrella opening statement you wish to make, Madam PS, and then we'll take it from there.
Okay, thank you, Chairman, and again, good morning to the committee members and to my colleagues. Well, we're here for MEGJC, and accompanying me is Mr. Everton G. Hunter, CEO, NWA, Mr. Varden Downer, his deputy, and Mrs. Judith Rob Walters, the Principal Finance Officer of the ministry. We have got our draft estimates, first supplementary estimates. We have noted the changes, and we are here to respond to any queries or provide clarification for any area that the committee may deem necessary. So,
well, one of my little pet one, I just go straight to Mr. Hunter on. The Junction Road. If my recollection is correct, you said you wouldn't need any more money to complete that work. Could you just give us a brief status report on that project?
Afternoon, Chairman, members. Okay, so the Junction Road project is actually two projects close by each other. The substantial Junction Road project, Toms River to Agualta Vale, Phase 1, that's completed. No additional funds are required for that element. Now, proximate to that project is the so-called Chovy breakaway, which was the subject of a separate contract. And unfortunately, most persons think of the two projects as one and the same, but they are, in fact, two discrete projects and were awarded separately. It is the Chovy breakaway which is now being implemented. Unfortunately, the order to commence did take some time because the contractor, as is the norm, was required to produce insurance and bonds, and the financial institution that he chose happened to have been a Trinidadian financial institution. And so there was a lot of deliberations between the government side and the contractor in terms of whether or not those securities could have been accepted. They have been finally cleared for acceptance, and the contractor has been paid his mobilization. So work will break out or has broken out in a significant way in the last couple of weeks.
What's the duration?
Initially, it was supposed to be 6 months.
Initially?
Yes.
That's 6 months.
We think that will hold substantially, weather being the issue.
That's a non-negotiable factor. Okay. In the budget, Mr. Hunter, there is an allocation for the South Coast Highway. Give us a synopsis of where we are with that project. 4.5 roughly billion being added to the allocation.
Okay. And just to note that for the 4.5,
yes,
it's for both NWA and NROC component.
Oh,
but it is broken out 60-40. 60% of the allocation goes to NWA and 40% to NROC.
Okay.
Okay, so in accordance with what the PS has just explained, one portion of the South Coast Highway Improvement Project is the segment from Maypen to Williamsfield, and that's been done by NROC. The NWA is responsible for the eastern portion, which runs from Harborview to Port Antonio. And that contract, or that part of the contract, is further subdivided into 3 discrete components. There is the Harborview to Yallahs Bridge component, which is a brand new highway, 4 lanes, median bar down the middle, and that is on new alignment, and that is being done by China Harbor itself. The segment from Yallahs Bridge to Port Antonio is on the existing alignment with improvements to the alignment of the existing road. And then there's a third component.
How many lanes on that portion? From
two lanes.
One either direction?
Yeah. But eventually, if you recall, the original highway would run from Harborview to Port Antonio on brand new alignment. And so for this phase, we are only doing Harborview to Yallahs Bridge on the new alignment. In subsequent years, we imagine that the remainder of the highway will be constructed on that new alignment. But for now, it's just Harborview to Yallahs Bridge that will be on the new alignment, and for Yallahs Bridge to Port Antonio on the existing alignment, with improvements along the way. And there's also the leg from Morant Bay to Cedar Valley, which is another discrete component. Incorporated in these works, as is now the norm, not only are we doing road works, but the construction will include drainage, sidewalks, retaining walls, water supply, and drainage, as well as ducts for fiber optic cabling in future. That project is scheduled for completion in October of next year. We are cautiously optimistic that we will meet that target. We've had some setbacks initially due to a reduction in the budget last year, you may recall, and there were some outbreaks, COVID outbreaks in the construction area, and that also impacted the progress. And again, because of the significant rain events that we had last year, that also impacted the progress. Suffice it to say that we have made significant inroads into the project portfolio as we speak. The section being undertaken by China Harbour itself, Harbourview to Yallahs Bridge, that's about 50% complete in terms of payout. The original five Harbourview, Yallahs Bridge to Port Antonio and Cedar Valley are in 15 discrete segments. We have already let 10 of those segments, and they are at varying stages of completion. And the last 5 segments will be awarded towards the end of December into January of this year.
So you're still on the October 2022?
Yes, we are.
All said and done. Are you behind now, notwithstanding you keeping the October, but based on where you plan to be at this point? Are you on schedule? Or is it that you have to make up to get to October next year?
The last 5 packages to be let, we're a little bit behind schedule in terms of when we would have, we had originally intended to let those 5. But we think that once we have awarded those 5, we can make significant inroads into the scope of those.
To keep the schedule?
Yeah, to keep the schedule.
Okay. What is your arrears like, NWA? Are all your payments up to schedule?
Yes, I should say that the Minister of Finance has been generous to the PS, who in turn has been generous to us. The biggest difficulty we have with payment relates to one head, and that's what we call flood damage. And flood damage is something that occurs every week. There are rain events all over the country. There are landslides. Drains are blocked, and we respond. The NWA is tasked with the responsibility to respond to these events.
Yeah. But as you know, Mr. Hunter, the arrears have been a recurring decimal in the public sector from time to time, or over time. And your ministry is one of the biggest capital intensive driven ministry.
That's right.
Specifically, I wanted to find out the arrears that you have. Can you say where they are now, if any? And secondly, for those that you do have, what is the age of those arrears?
Okay, so as I indicated, we only have arrears under one head, which is
the flood ones.
The flood damage. Now, because our operation is a going concern, what we can give you is at a point in time. As of now, it is about $200 million.
200 million.
We are in the month of October, and as you know, the rainy season peaks September into October. Providing there are no additional events, we should be able to clear those arrears in good time.
What good time means?
Well, I think there is a provision before Christmas. That would be
so by December,
our
the 200 million should be cleared.
We should.
Okay.
Providing there's no event, because again, as I said before, it's a snapshot. Because if there's an event tomorrow, then
there are more expenditure. Fine. But remember, Hannah.
Mr. Hunter.
Madam.
My concern has less about to do with the monies allocated, because I know it's never enough. I know you don't have enough money to do the kinds of works that are necessary, even with the rains that have happened. And as members of Parliament, I think you know more than anybody that our constituents believe that we're road engineers as well. And somehow, it is our responsibility to fix the road. I have seen too many instances, though, where we have even grade 1 contractors who put up the bonds and the insurance, and by the time the rain fall, 6 months later, the road wash away. I would hasten to say that with all of some of the roadworks that I've even seen in Kingston and St. Andrew, right now there is a space on the boulevard right before you reach, I think, the milk factory. If you don't slow down, there's a major situation right there. Sometimes I fix the road, piece said sink, and you're driving at a speed. So the question I'm asking, Mr. Hunter, what exigencies do we have, or does the NWA have, when a contractor is given a contract to fix a road, after it has been inspected, and let us say it rains, and the road surface does not stand up? Whose responsibility is it therefore after to fix the road? Is it that contractor, or does the government have to come back in and find the money, or the member of parliament have to come back and find the money to put back? Because I find we just keep putting the same money. You see the annual patching program in constituencies, and I'm grateful for it, but it's almost as if you're patching back the same said roads every single year. So I want to know, at what point are we as leaders going to say, look, if you fix the road and it liquor rainfall and it mash up, this is what it is? Do we have a system in place? That's the first. And then I have a question for the PS after on water.
Member Hannah, thank you for your question. And I recall in our conversation you and I had some weeks or months ago, you indicated to me that you no longer wanted any patching to be done in your constituency. You wanted total rehab. And that is exactly the point. The point is this: we have never been able to fund our road portfolio sufficiently to do what the engineering manuals prescribe. What we have been doing is patching roads that ought to be totally rehab. Rehabilitation involves removing the driving surface, the asphalt, because it oxidizes after a number of years. It develops crack. The water gets into the cracks, into the sub-base, and that causes the road to deteriorate. So until and unless we are sufficiently funded to be able to carry out such a program, then patching is what we have at our disposal. The engineering prescription for road maintenance is fairly well established internationally, and we subscribe to that. The difficulty that we have is because there is no predictability in terms of financing, it is hard for us to do a kind of long-term rehab program. So once we have our budget, for which we are grateful, we then try to allocate as best as we can, taking all factors into consideration. And so we end up approaching a particular problem more so from a financing point of view than a needs point of view. So for example, if you look at the budget, where we have $54 million for drain cleaning, there's no illusion that that is addressing need. It is not. What our prerogatives therefore become, what's the best spend for that $54 million? So there are two different things. I'm not addressing drain cleaning needs with $54 million. I'm spending $54 million in the best way I can. So yesterday we're here, I remember the governor of the Bank of Jamaica talking about expectation. So it's the same thing. If one has expectations of need as opposed to expectation of spending, then there's a disconnect. Contractors, again, it's a truism. To the extent that we have good contractors working for us is the extent to which we are heroes. If managers will always take decisions that inure to their longevity. So if it's left to me and me alone, I would always choose the one or two contractors that makes me look good. But regrettably, the government's rules for engaging contractors does not afford me that luxury. The government's rules are predicated on transparency, equity, and value for money. And so we go to tender and we get the contractor that on the face of it appears to, be the most suitable in the circumstance. Unfortunately, some contractors practice their craft on our reputation. So if the contractor is good, he gets all the praise. If the contractor is bad, I get all the brickbats. But suffice it to say that there is an initiative in government now for a contractor performance matrix. We have done 2 presentations to Infrastructure Committee of Cabinet in terms of how it will be rolled out. The intention there is not to eliminate contractors, but really to get them to lift their game. The only tool that we have in terms of a contractor's performance is really not to pay him. Contractors don't get paid unless the work matches our standard. And we hold to that.
So I ask a question. There is no warranty on the job. In other words, in your performance matrix.
Yeah, understand. Yeah. It's called the defects liability period. And generally, the extent of the defects liability period depends on the value of the contract. And it can vary anywhere from 6 months to a year. Normally, it's a year. Now, the question is, should it be 2 years or 3 years? Well, the truth is that if you want 2 years warranty, you pay for it. So a contractor is not going to be held responsible for something 2 years down the road unless you pay him regally for that.
I had it. Thank you, Mr. Hunter, for clarification. The other question I had, Mr. Chairman. P.S. Was it this year?
Madam.
Yes. I had raised a concern about water trucking. There was $15 million in the budget. On page 19,004 in the supplementary.
Gone to 5.
It gone down to 5 million.
Because, as I had explained before, that the trucking of water.
Hold on, PS. I don't even ask a question yet,
Yes, but I shouldn't be answering about trucking of water because it is no longer in my ministry.
So what you're saying, this 5, I don't ask a question yet. Because when I asked, hold on, PS.
Yeah, okay, go ahead.
When I had asked a question originally, I said the 15 million was too small for the 63 constituencies because when you max it out, it just never worked out. You're saying that it has been moved. So 5 million is left in your jurisdiction now. Where has it gone and has any more money been added to it? Or is it still?
It was transferred more than a year ago to the Ministry of Local Government and Rural Development.
I'm glad you raised that.
Yes.
Because when I went to the minister, because that was the same answer I got earlier this year, and I said to him, because at the time, the minister with responsibility for water said to me that that is where it was, and then there would be some more thing. When I went to the Minister of Local Government, he said, look, I'm not aware that any more money is going to be coming there.
Well, when we can only speak to what happened when we transferred it. Whatever we had left in the budget, we transferred the assets and everything. Whatever we had in the budget at the time that it was transferred, which I think was March 2020, we sent that balance. Under the through the approval of the Ministry of Finance, we sent over all the funds. We kept a small amount because we had some mopping up to do, where some constituencies would have, or municipal corporations, they would have given out work and the invoices had not come in as yet. So we thought it was still our responsibility to ensure that those were paid. Also, it was said that in case of an emergency, and because we are doing, say, the Hope, there is the need at times in terms of water for the persons for whom we are building houses, and we may have to do some work in that regard. Hence, the small amount of $5 million is there, but it is not that, it is our responsibility. It was transferred by a cabinet approval, and I cannot say at this point in time whether they have got more money or not. I think that question is best directed to that ministry.
No, I see 20 million in their budget for the trucking of water.
Yes.
Right? And so what you're saying to me is that the savings, you sent 10 over there and perhaps
No.
another 10
At the
was
time,
given?
I don't remember the exact amount at the time when it was transferred. But all the assets, all the funds that we had in the budget at the cutoff time, everything was transferred to that ministry. As to what has transpired since, I am unable to comment on that.
And the members have any other question for Mr. No, Mr. Hunter, not so quick to run. Okay. Thanks very much. And we will be in touch again.
One question for Mr. Hunter. Mr.
No,
Hunter,
I
we're
won't
going to let
permit
you
you to
run.
ask him any
I
more
just have
questions.
one question for you. I know the answer already because the minister spoke to me yesterday. I'm asking you to go back and take a look at the Bull Bay police station so that it is finalized if money is going to have to be sought by the Ministry of National Security, or if somehow as a part of your budget you can squeeze what is required to do the police station. That's all I'm going to say.
Yeah, that was really for the records here.
Because we wrote to National Security
FS is
and
here,
told
you know,
them.
don't forget FS is here. She has been quiet, but she may be taking it back to the Ministry of Finance on your behalf.
Yes.
We
But
did
it
write,
has to
though,
go
Madam,
somewhere.
to the Ministry of National Security to tell them that we are unable to undertake that expenditure as part of the project, so they should consider seeking funds, and they didn't object. So I am hoping that they will be able to procure the funds.
They will be able to when they get back some of the used car money.
Cannot be under the project. We can't find the funds to undertake it. And what they're asking too, because it would be beyond the scope of the project, yes.
Okay. Mr. Hunter, just one before you. The secondary roads, that one I just skipped over on my list. You have how much? Like $1 billion for secondary road repairs. How are those going to be selected? Those roads are going to be selected. The $1 billion that you have allocated.
Chairman, they've been selected already.
I want to confirm that.
But I want to see the ones that have been selected
Yes.
and how much money has been allocated to each constituency. That is what I like see.
That's why I asked how the selection will be done, you know. But Mr. Anna is ahead of me. Have they been selected already, Mr. Hunter? Have they been selected?
No, they have not been selected. Chairman, let me say, and let me be as candid as I always am. The selection of roads for an intervention, it doesn't follow an academic formula, okay? Our posture at the NWA is that once the age of the road passes the 7-year mark, they are all on the table for rehabilitation and some kind of intervention. I know that there's a thesis that says one should do a comparative analysis, and that analysis will say your road is more crucial than my road, and so you end up peddling in discontent. You know, it's like saying, you know, you call me about your pothole and somebody else calls me about their pothole, and I'm to do, you know, some kind of analysis that tells me which pothole is more important. I mean, that really doesn't get us there. What I think we should focus on, and what we are trying to focus on, is to try and increase the size of the pie that we get so that we can have a more comprehensive approach to fixing roads.
With all due respect, we know that, but the simple question is, with the 1 billion that you
how will we select?
How do you,
okay.
Yes.
So, as I said, we have the NAA staff carries out periodic reconnaissance of all the roads under our portfolio. So we get that input from them. So that's one. Two, MPs, civil society, custodians, everybody else, the newspaper, people bring to the fore the need for rehabilitation. We then sit down, yeah, and we look at all the needs that have been expressed, we look at the costs, and then we make a decision. Here's the issue. If the cost for rehabilitation of a particular road is $300 million, we're not going to do that out of the $1 billion. Yeah? If the cost is $150 million, as is the case with a lot of the roads, we're not going to do it out of the $1 billion. What we will do is try and spend the money in discrete portions, 15 million, 20 million, based on all the needs that have been expressed to us, as well as our own it's an iterative process. Okay. So you are free, Chairman, to express your desires, your need, as has been the case in the past. Every MP here has contacted us from time to time with their needs, and we try to do the best that we can. But there's no perfect formula to tell us exactly which one, because really it's peddling in discontent.
Or minimizing content.
Well, I tell you what in a minute, Chairman. As Member Hannah just said a while ago, when I try to minimize discontent by patching, it doesn't get me very far because they say they want rehab. So I'm a very practical person. Patching is the best we can do. Sometimes it's not every pothole we can patch because we allocate a certain amount of money for an event and we stretch that as far as we can.
Okay. All right. Members, I think we're going to call it a day there. Thanks, Mr. Hunter. Thanks, PS. Well, and I invite all other members, they can be directly in touch with Mr. Hunter for their respective roads. Thanks.
Mr. Chairman, it is now 5 minutes past 1 by the clock above. We need to...
Members, we have the Ministry of Education here, which is one of the very critical ministries in as it relates to the supplementary budget and the crisis, I think, that drives the supplementary budget, which is the COVID situation. I would like us to, I think we can 5-6 minutes after. Yeah, it's going to take a little while. And this one is a very, very, very deep ministry. No, we don't do it properly, or we don't do it at all. Members, we have to make a decision. Today is Wednesday. We could I don't want to do any disservice to the deliberations of the committee on these matters. Tuesday morning? Yeah. Mr. Just a second. Members, one of the logistics that we have is we're trying to accommodate the Ministry of Finance as much as possible in disposing of our task here. I just consulted with the consultant who will involve in drafting the report that would be subsequently tabled in the House. Madam PS, I know you've been waiting, but as you have seen what transpired, we can meet on Tuesday morning and we can do Ministry of Education. We could start, yes, and then we could, members agree to meet back on Tuesday, and the consultant has assured me that we can have the report ready for tabling in the afternoon on Tuesday. So we'll just proceed with Ministry of Education, see how far we go, and then Tuesday morning we'll still come back to deal with the other two ministries, other ministry, which is Ministry of Labor and Social Security, and local government, which that one won't be long, I know. Right. So, PS, welcome. You are in a very familiar place. I dare to say you're very much at home. As I mentioned in a passing way just now, the Ministry of Education is one of the foremost ministries as it relates to the supplementary budget before us, and adjustments that are required in the government's allocation of funds. You want to start out by give us a brief overview in terms of the funding to start with, additional funding that comes to the ministry's program going forward for the rest of the financial year.
Okay, good afternoon, Chairman, and good afternoon to your members and to our FS and DFS Jarrett. This afternoon, I have members of the ministry's team here with me. I have our Chief Education Officer Acting, Dr. Kesson Troop, Mrs. Sonia Banton, our Principal Financial Officer, Mrs. Philippa Grant-Smith, our Project Officer, Mr. Kerry Brown, responsible for Infrastructure and Technical Services, and we also have the Acting President of UTEC, Professor Colin Giles. So, Chairman, as it relates to the recurrent budget, there is an increase. There are some areas that have been increased and some areas where we have been able to reallocate. So when this is fully calculated, there's an increase of 571.3 million. So the new estimate is now $115 billion, of course. Now, the key areas of the recurrent budget, the main area has to do with the additional support that is being provided for UTEC based on their financial situation, which was carefully interrogated by the Ministry of Finance and supported. We also have some allocation, some increased allocation for payment of utility bills. Of course, during this period when so much is dependent on internet and bandwidth, so there are some payments that will be done for institutions which are mainly for Digicel. We also have reflected the transfer of funds to the Ministry of Labor and Social Security for the transfer of funds to the accounts of families who are on path, so the students can at least be provided with lunch. And we also have a reallocation from the ministry to support the Maxfield Park Children's Home through the Child Protection and Family Services Agency for payment of their utility bills. And on the capital expenditure, this has a slight increase. It is now at $1,164 million, and this really has to do with some reallocation that we would have taken into consideration based on the delay in some of our capital projects. So these are the areas for the draft supplementary budget, Chairman, and we now await the questions and interrogation accordingly.
Thanks, PS. On the capital side, the capital amount, you just repeat what you just said. The amount you gave.
Right. So the previous approved estimate was $1,163 million, and the new estimate is now $1,164 million. So just a slight billion.
Yes, that's where I was a little confused.
$1,164 million. So just a slight increase of $1,403,000.
And essentially, that addition is to deal with what specific capital projects?
Right. So that addition has really been placed through one of our partners who occupies space on the capital budget, which is the UNICEF Child Friendly Project. And so there are some support in terms of phones, closed user group phones, to assist in terms of just to deal with the many telephone calls to deal with mental wellness and also counseling of our various constituents. So they would have provided support initially for these, and now we have it reflected in the space for the capital budget.
On the capital side, well, one of the areas that I have particular interest in, and in the period of the coronavirus, is the tablets and computers in school. Okay. As you know, that is the major impediment for the learning exercise to carry on in the absence of face-to-face. That's one. If you could give us a synopsis on that from where you are. And I like to get numbers, PS, that tell me where I need to be and where I am, so I know what gap there is that we need to close. It gives us an appreciation of the extent of the journey that we have to cover. And secondly, I would also like to get any report you have, which I think it would come out of collaboration with the Ministry of Health in terms of the level of vaccination for teachers within the school system. And then there's some member Hannah has some questions. We want to deal with those two sets for me, and then we can take the other.
Okay, Chairman. So let me start with the provision of devices to assist our students in online learning. We have a total committed of 126,722 devices, and I'll just give you a quick breakdown. We have 40,000 tablets that were procured for grades 4, 5, and 6, and at about 98% of these were distributed in the previous school year, and the additional we are currently distributing. We also procured 15,000 laptops, which were procured for our grades 10 to 13, and let me just say these are students who are on the PATH program, and these also were distributed. We perhaps have about 1,000 or so that would not have been distributed as yet, because of course we have to make sure that the students do come in to sign and all the necessary paperwork in place. So that's currently being done. We are currently procuring 16,000 tablets, and of course these are being handled through eLearning Jamaica, and these are for our PATH students from grade 7 to 9. The Own Your Own Device program, phase 1, we have so far redeemed 25,277 vouchers, hence devices, and we have gotten up to the mark of the 36,000. So we are just waiting for parents to go into the vendors to redeem the vouchers, but we do not have the full 36,000 represented here. So when they are redeemed, then we will add that to the figure. The one laptop or tablet per child initiative has been going really very well, and we really thank private sector and the diaspora. We are now at 21,411 devices, which include tablets and laptops that have been distributed to students, and these students would not be our students who are on PATH. We also would have provided 130 tablets for our, well, not 130, 730 tablets for our special needs students, which include both PATH and non-PATH. There was another 2,000 that the ministry also procured for students who are on the alternative pathway to secondary education. And currently, we are just about completing the preparations for the OYOD, the Own Your Own Device program phase 2, which will see us providing vouchers for our students who, this program is actually for the members of parliament and councillors, I believe, the SURF program, and that total will be 6,300. And there we have an additional amount which is not included in this 126 for our additional students who are on PATH that would have been in the number that I mentioned for grade 7 to 9 earlier, as well as procurement of tablets for teachers as well. So, Chairman, this gives us a total of 126,725, and through the heads of agreement with the Jamaica Teachers Association last year, we provided 26,033 tablets to our teachers. Chairman, we can't say that we are close to providing a device to every child. We are projecting that we have approximately 450,000 students who would require to have at least device to work with at primary and secondary, and to a limited extent, some of our infant schools would be included. So we still have a far way to go in ensuring that a device is provided for each child. But let me, however, say that we are seeing, and my CEO will speak a little more about this, over 300,000 of our students are being engaged in virtual learning, which means that they perhaps may be using their parents' mobile phone, or they are going to a location where there is a device, a desktop, that is being used. And so we still continue on this drive to see how best we can provide the instruments that are needed by our students.
While you're on the equipment provision side, could you also comment on the connectivity side? Because one of the complaints we get is that there are many who are not able to log on.
So, yes, Chairman, I can't say that we are proud of the connectivity across the country. This is not only in our deep rural and hilly areas, but also even in the urban areas. We have found that sometimes the connection is less than acceptable, and sometimes our students are in and out of the classes because of the connectivity. Even us at work, sometimes we have those challenges. I will say, however, through partnership with the Ministry of Science, Energy and Technology and our ministry, we have been at this for almost a year now, working through doing the audits of the system. And I believe we are at a stage now, as you would have heard, I think it was last week in Minister Vaz's presentation, where he outlined the different tiers. And just to add to that, we have one tier which comprises 661 public schools and 48 children's homes, which we now have a procurement out under the wide area network category or tier, and we are expecting that contracts should be in place by the end of December. We are far advanced in terms of just receiving queries and suppliers preparing their bids. We also have another procurement that is out for satellite provision, and we have 481 schools that are a part of this procurement, and this is also far advanced as well to be completed by the end of this year. There is also the massive project of having our schools connected to the backbone fiber through GovNet, and there are 364 schools that we have identified. 20 of these schools have already been connected and are really benefiting from a greater internet experience. And we also will be adding our tertiary institutions to the fiber network connectivity. So, Chairman, I believe that once we have completed the procurement of these three programs that I've outlined, we should see every single public school in the country being able to access the internet. Now, we have not yet asked our schools that would have taken out their own internet connection by virtue of funding sent to them by the ministry. We have not asked them to discontinue their service arrangements as yet, but we are currently doing an audit of those service arrangements to make sure that there is no fallout or any duplication when it comes to switching when we have a contract. So, again, Chairman, I will say we are not there, but in terms of the coordinated strategy that MSED has been guiding us through and providing the technical support, we believe that by 2022 there will be much better connectivity of our public schools across the country.
Member Anna?
Thank you, P.S., and welcome to the other members of the ministry who are here. It is good to see you. This is an extremely important ministry, and certainly it is against those opening remarks why I have chosen to say what I need to say. Because I think one of the biggest fallouts, and the statistics point to it, because of the pandemic, is the learning loss of our children, certainly in the Caribbean and Latin America. And if you look at the statistics, which I was doing recently, 3 out of every 5 children have missed a year of school, face-to-face interactive learning in Latin America and the Caribbean. It's even more stark here in Jamaica, because when you dig further into the specificity of the information, what I saw was that 50% of schools were only able to give about 3 hours of learning a day online, which amounted to about 3 classes a day, and about 32% of them could only give 1 hour. And so when PSU came here earlier this year, and you were speaking about some of the learning loss situations that students were experiencing, I think all of us breathe a collective sigh of distress, especially for the grade 6 students who, in your report, basically you were saying that, look, the majority of them were getting only 50%. And that was also addressed at the grade 5 level and the grade 4 level. I remember when I asked you as well, we had to keep moving them forward because we really don't have the space. In October of last year, at that time of about, and I remember the numbers well in my head, about 381,000 plus students who were registered, only close to 70,000 of them had access to a digital platform. Didn't mean they owned one. It mean they probably had access to their mother's phone or something. And then that number grew to about 148,000 in November. So I know the ministry's push to try and get children online. And I also remember that you had access to television and other modalities that you were using. But all of us in here who are seeing the realities and feeling them, especially in our communities, listening to our teachers, meeting with them. I was listening to the minister last week, Minister Darrell Vaz, and he spoke to the fact that 189 UCF hotspots had been identified. I have 2 now in my constituency, but they're at the main central points of libraries. They don't go into the hilly interiors of the country, which is really where a lot of the students need connectivity. But you spoke about the backbone a while ago, and Minister Vaz also spoke about the fact that there needs to be another 200,000 meters of fiber optic cable wires going from St. James to Portland. And in the municipal areas, there needs to be another 300,000 meters of fiber optic to connect to that backbone for students. I raise all of this, PS, because there was a very interesting program that the minister came to Parliament and announced. She announced 3 things that resonated with me. One was the fact that in the history of Jamaica, they'd never given out so many tablets, and she was able to come and speak about the tablets. 2, that of the 211,000 plus children who were vaccinated, about 78,000 had been vaccinated to date between 12 to 18. And then she spoke about another program, a community intervention program, which was to deal with the learning loss. I am sure Member Holness is going to speak about vaccines, so I'm not going to even talk about that because your numbers were not accurate. I want to speak about the intervention program with the boots on the ground because the minister spoke to the fact that you were able to intercede and access 2,300 children who were able to get about 5 hours in groups of small 5, I believe it was, and you were able to give them classes 3 days a week for 1.5 hours a day. That program is critical because in the communities now, it's all good and well, and tablets are important, but if you give out tablets and digital equipment to students without supervision and without the critical parental support or teacher support, it's not going to have the kind of impact because we're seeing it in the numbers too. That's why you need more boots on the ground. And that community yard-to-yard intervention program that the minister spoke about needs to be ramped up. Because from what you're saying, I haven't even heard you signal to the country when face-to-face classes are going to start. And I don't know what the vaccination rates are for teachers either. And the truth is, our children need to get back to face-to-face learning. If we don't get them back to face-to-face learning, we're going to have a serious learning deficit in this country. So I don't see anything in the supplementary budget either to talk to that program of more boots on the ground to help our children who may not even have access. Take them into the community centers, take them into the churches, have those groups of 5, right? But it needs to happen, and I'm not seeing where it is budgeted for. Because I believe right now, in addition or in tandem with the tablets program and with what the ministry is doing, we have to give them back some face-to-face interaction with teachers. If we can't get them in the classrooms need to go to them. And so my question is, where are we going to fund that program so that when the minister comes back to Parliament, she says that we have been able to exponentially increase from 2,300 children to all 50,000 children, because that's where we need to get to. PS.
Thank you, Member Hannah, and I concur with you regarding the learning loss of our students, which is really occupying our minds at the ministry as well. I'll just say briefly about the yard-to-yard Finding the Child initiative. This program is to assist us to find those students who have not logged on to virtual or who would not have been getting learning kits or even accessing our television and cable channels. That program, the framework, speaks to a total of $95 million that will be required for the general support. We have been able to find funds internally based on, of course, what has been happening since COVID. So we were able to reallocate from our goods and services budget to afford that. Now, this program will see us recruiting over 560 young people and over 120 guidance counselors and social workers who will be working with our schools, attached to schools, but working with our communities in finding those children who are not being engaged. And there's a motivational component that is included. While I am yet to have a discussion, Dr. Troop and myself, with Minister, the suggestion was also made that we ask each member of parliament to provide us with the names of 40 young people from each constituency who we can utilize for this purpose, because we believe that as members of parliament, you are in the community. The young people that you have access to, they will know the inner terrain of the community. So we do not want to be getting persons who will not be able to go into the deep rural areas, speak to the grandmothers, and speak to those mothers and fathers who are just not sending the children to school. So that is a plan, and I await Minister doing a formal announcement for that program. Now, what I'm going to do now, Member Hannah, is to ask Dr. Troop to speak about the engagement rates and also the face-to-face extra lesson intervention program that will complement or support the yard-to-yard initiative.
Before she goes, though, PS, tell me the number of students at the secondary level between 12 to 18. Is it 211,000 plus? Give me the exact.
204 in our public schools, member, but I will say perhaps there's another 10 to 12,000 who may be in private institutions, but we can't speak to the full accuracy of that because sometimes the information is not submitted.
And the 95 million is largely to pay salaries of teachers, or is
so?
Is
the 95 million is.
And
to
how many
pay,
students will it be able to access in the learning loss situation before the doctor comes?
So the yard-to-yard Finding the Child initiative is to find those children who have not turned up. And Dr. Troop will provide that number. So it's to find them first and foremost, member, and to encourage them that school is still keeping, and they have to access whether in a community center, a church, or the school that is nearby, and to make a commitment that yes, they are going to be coming to X place, or they are going to be able to come on virtually. So there's an app that is being created where the young people will have that on their phones. We'll provide phone credit, of course, and they can put in the information that will feed into Central. So we have the data almost immediately to manage the numbers, and we can now transfer them to the extra lesson program, where the team will ensure that they are in the community centers or in a church or wherever those 5 persons will be meeting for the face-to-face intervention. So that's how it will work.
Just an additional observation for Mr. Chair, for PS. When you do the program of search for these students, do you factor in your budget the resources to supply the means for them to come into the program? Because it is likely that some of those students would have been out of the program because they don't have the means to get in. So do you, have you budgeted for that in your budget?
Right, so...
Yes, before you answer, since we know you won't have much time, I'll add to it. I actually had no interest in asking you about vaccines because we got enough answer from the Ministry of Health to leave us with grave concerns about the resumption of face-to-face. Where I wanted to go was the exact thing, and I appreciate...
Member Oles, it is now...
I know.
No, it is now 1:36. No, as we had said before, we tried to utilize whatever time we had with the ministry here. But I will have to cut now. The minister will come back on Tuesday morning.
Meaning they would not answer the question today?
No, I'm just going to, if it's an extension, I'm
All
trying
right,
to curtail.
So what I'll do is leave the question and they can answer it afterwards. So my concern was, as members of parliament, principals I've spoken to would be able to say to me, look, 20% of my children are logged on, and then by 1 o'clock, I'm down to 10%. When I check, the same individuals are logged on consistently, and the same individuals are not there consistently. I know you're now going to roll out a program, but I want to know as members of parliament how we could further help you. Because if we knew the students who are not accessing regularly, we would be able to reach out to many of them. And more importantly, the ones who are cutting off at a particular point in time every day, it means that they're running out of credit. So we would be able to target them because they have the interest to be there if we knew who they were. That has been a concern in just engaging us as members of parliament to help with the process of having our children being able to access the information. And secondly, does the Ministry for Secondary Education, maths, English, whatever the subjects are, have enough taped classes that we know can take to the individuals who are not able to access and get our children back up to speed?
Yes, I want to take that as just an advance notice.
Okay, sir.
Because there are some other questions emerging from that too. When Member Anna raised the question of the equipment out there, the whole quality assurance element to it, which we'll want you to really elaborate on. So I'm going to take those last questions as notice for question, and we will take those among with others when we come on Tuesday. We will start very, very much early, so you won't be here for very long after. Okay. So thanks to the Ministry of Education. Sorry that we have to abort this portion of it, but we have to exit the chamber. Our time has long passed to prepare for the sitting this afternoon. So once again, thanks, and we'll continue on Tuesday morning.
Okay, Chairman. Thank you, and thanks to your members as well.
Right. Member, could I have a motion for the adjournment? Okay. Thanks. Meeting is now so adjourned.